it generates in one acquisition all these different contrasts. For now, just on the axial plane, but the 3D is coming of all the echoes, T1, T2, flare, T1 flares. This is just a sample. It's about 12. It's about 12 contrasts, right, John?
Right.
It's about 12 different contrasts that get generated in one acquisition. On the same acquisition are generated all these maps. There is not only these 4, it's about 6 or 7. And all these values, R1, R2, Breton density, T1, T2, and all these curves. And the curves are standardized by age. So the curve means plus minus 2 standard deviations, that's where the yellow dot falls. And you can see immediately in the studies that we're going to see where it goes. So you get maps, you get curves, you get a report with actual numbers that are standardized by age. So it's all very automated, very smooth. You can do as little or as much as you want, and we'll get into that next. So that's all the different contrasts. You know, the sequence takes about 5 minutes, but if you have IR tools, it can take 3 or 3.5 minutes, meaning Eric on DL on GE, Deep Resolve on Siemens, or Smart Speed on Philips. The acquiring this sequence can take about 3.5 minutes. Next. That's the report that is also automatically generated. Like when the study is done and it's sent to PACS, it immediately comes with this report. It doesn't need any additional work on your side or technologies or anything. The system automatically generates these reports with all these different values that are standardized by age and all the curves with it. Next. So if you want to do it manually, you also have the ability to use the portal. So in this portal, I'm just showing 6 maps, but like I said, there is a huge selection of things that you can do with different windows. You can modify how much T1 or T2 weight you want it, but you can modify the contrast. This is when you want to manipulate the images yourself. All this can be automated. You can tell the system, I want you to send me these maps and these echoes. You can all that can be pre-programmed and then sent later, or sent at the same time that the study is done. Or you can open the portal yourself and play with it, like I like to do. Next. And there's all the different echoes. I particularly like the PSIR and the double IR. They're very useful. I'm going to show you. I just want to point out how beautiful, like for example, the flare is. It's such a much nicer flare than the flare that we actually acquire with the machine. Like our own.
It's not so mushy.
Yeah.
You know what mushy is?
Yeah, like you mean flat?
Yeah, just like that.
Yes. Yeah, like it's a lot crisper. Yeah. So yeah, with that acquisition and what the system does, you actually get better images than acquiring each sequence individually, which is interesting because it has motion compensation. It has also correction for metal artifacts, like when the patient has a shunt or something. You actually see that the metal artifact less on this sequence that you see it on the conventional sequences. And you can do the whole thing in just 3.5 minutes. Next. So just a few background studies, right? Because we always have to show that it's been published, that it's being validated, and that's what we're just gonna very quickly show. Basically, on multiple sclerosis, showing that there is demyelination, but not only on the lesions, that it's not important to follow the lesions so much as how is the global myelin in the brain going. So MS shows a global decrease in myelin in the brain, not just on the lesions. So this kind of like measuring lesions and enhances, doesn't enhance, it doesn't matter. What matters is how the whole brain is doing, and that's important for following like response to treatment or evolution of the disease, if it's relapsing remitting. So it changes the paradigm a lot of how we evaluate MS by imaging. Next. And show that, same study, how this is a normal individual, and you can see how the yellow is more myelin, the green is less, and this is an MS patient, yes, you see it's got a few blacks here that, you know, usually we'll see in our practice. Yeah, it's got a few, like, I mean, we know it has MS, but in reality you see this and I'm like, well, there's some few.
Just from a clinical point of view, we are particularly interested in what you just said, that you can get an idea of the so-called normal appearing white matter. Could you comment on that, or reliable?
This is very reliable.
Impressive. You see a degradation of the myelin, even in areas where there are currently no lesions.
Absolutely, and not only in MS, I'm going to show cases of it, but yes, and that's why I'm showing the article first, because this has been published, validated, so, and this is just an example from the article. I'm going to show you cases on my own, but this is from an article, so you can see that this has already been validated. This is from the Karolinska Institute. You can see that in this case, that these lesions are not very specific. That you might even say, well, there are a few, like maybe little infarcts, like they are not like the classic dozen fingers or anything. But you can see that even in areas like you see a lesion there, but like around here, maybe not, but you can see it in the map that it's clearly diminished globally. It's very obvious that it's not just the lesions, but everything else in the brain. So, next, and we're going to show more.
The appearance changes.
Oh yeah.
The appearance of the whole disease changes.
Yeah,
right?
and I'm gonna show how the numbers change, the volume, everything matches. You know, it's not just, you know, some subjective thing, but it's not just MS in trauma. You know, like this is a normal appearing individual, and this is a case of a patient that had a traumatic brain injury. The regular T2 showed nothing, and the myelin map shows there was 5 standard deviations below normal. The global myelin on the brain after TBI, and that's also published.
Do you recall the SWI in this patient?
Yeah, it didn't show anything.
Didn't show anything?
It didn't show anything.
Seriously?
Yeah. Yeah, the article is there. It didn't show anything. So it's just, you know, it's showing like it has multiple applications. So that's something very impressive. Some very general and all these published and validated. Same to follow up on myelination. That can be hard. And I actually have a case where like it allows us to see how the myelination progression is, and it's all validated by age. So you can go to some atlas and try to see, well, is there internal capsule, is there corpus callosum, is there, like, well, it takes a long time. The map will give it to you immediately. You can see immediately what parts are myelinated, and it will tell you the myelin is abnormal in this kid, and then you start looking and, okay, yeah, it's abnormal because this is missing, and it shows you right away. Again, validated by article. And a really nice article from Cincinnati's children. So I have a case.
This is normal, yeah.
Yeah, this is normal, yeah. For age.
Yeah.
But I'm going to show a case my case that is actually abnormal. So I'll show you in a bit. Next, microcephaly. This is my favorite. Why? Because we see that there is some increment on the benign increment on the subarachnoid spaces. Next case, right? Yeah. Well, the clinicians say, yeah, benign, whatever, but the head is huge. So it's like, well, I don't know, I don't see much. Well, you don't see much, but the volume is like 40 standard deviations above normal. And on follow-up, it gets even worse.
Yeah.
And will you compare this with that? I mean, can you really tell? Like just by looking at images, it's like so much worse.
So this is now the volumetry? Or
Yeah, this is the CSF volume. This objectively measuring CSF volumes. So now we're seeing that when we see an image, when we actually measure the volumes, you can see.
Okay, this is now the CSF.
Yeah, it's a CSF volume. Yeah.
What about the myelin in this case?
No, this is no myelin map. This is a CSF volume map. It's a different map. We can do myelin maps, and we can do, and they are all generated at the same time. You have them all. You have the myelin map, and you have the CSF volume map. You have it all. But in this case, for macrocephaly, we're just looking at the CSF volume. So we can objectively evaluate this macrocephaly case and say, yeah, there is a really bad increment in volume, even if the images don't look like much. So.
But the clinical.
Yeah, the head is getting bigger.
Okay.
Yeah, but then like why? Why? Because that's what we scan them. Basically, our report has to match. And a lot of times, I don't know if I would have said that there is much difference in the CSF volume. Just looking at the standard images.
Oh, I see. So now you can tell, okay, there's a steep increase, and
Yeah.
so possibly you'll have to become, you have to make consequences, shunting.
Exactly.
So there's more of a standardized reporting for the neuroradiologist versus objective.
It was more objective. Next. And also in developmental delay, you see that the brain parenchyma fraction, that's a number that I give you, it's normal. But the brain parenchymal volume, it's below. The myelin fraction is within the normal range. So this is just a global brain growth problem rather than just volume loss. That's an article that was published in Cincinnati Children's.
Can you elaborate on that? I didn't understand.
The fraction that you see there, brain parenchyma fraction, the one on the left, that looks to be close to the mean value, that white line where you see the yellow dot.
Yeah.
So that is the intracranial volume as the denominator. You have the brain parenchyma volume divided by the intracranial volume. So functional tissue divided by internal.
But everything that is inside,
yeah.
like brain and CSF.
And what they were able to determine by looking at the lower than normal brain parenchyma volume is that this was consistent with brain growth rather than being consistent with atrophy or something else going on.
So it was a global brain growth problem rather than just a decreased myelin or a volume loss. Anyway, next study. And then same thing that we did for macrocephaly for like CSF on the extraction spaces. Now we can do it on the ventricles and objectively see how is the increment in volume in the ventricles, rather than trying to measure distances and measure the volumes. We don't need to measure the volumes anymore. We can just follow it up with the volumes themselves, which is a lot more objective and a lot more standardized. So you see, for example, in the first scan, the CSF volume is 238. In the second scan, looks bigger. Now it's 413. And the same on the next one, like this one and this one, now it's 443. And now from here, this is 340. So it got shunted here. You can see how it got shunted. Like there is a little air here. So between this one and this one, there was this shunt placement, and you can see how much it changed after shunting. So you can objectively see by volume how it changed, rather than just trying to be measuring it. Like if you try to measure like this, these look quite similar, honestly. Like if you just look at the images, they look very similar. Maybe this is a little smaller, but you're like, it's not really. But now you can see, yeah, it's 100 milliliters less. So it's not a little, it's a significant.
So you can express it in numbers.
Yeah.
Can I ask another question? Does head angle also confuse you guys when you're...
Absolutely. He has a good point. Like sometimes when we have to look at this and start measuring and trying to, let's say, if the ventricles are bigger or smaller, the angle of the cut can be different, and that can also be altering our perception. But now that doesn't matter because we have numbers, so we know exactly, how much more or how much less CSF there is. And you can see the change of value in the curves. Next.
Please, just go back. Wait 1 second. Just one more. What you can, I agree with you with the size of the ventricles. Yes, it's difficult to see that there is less CSF. but you can't. I don't want to. You can't see it in the outer spaces. Subrectal. It's visually seen. So I want to say, even people who don't believe the numbers in this case, we also have a hint in the images, right?
Right. You can
Can
see.
we agree on that?
Yeah. What you're saying is that the subarachnoid spaces are bigger than here.
Like from the third to the fourth.
Yeah.
We can see that, right? And it's
Yeah. Absolutely. But like.
but now we can have a number for it. It's
Right, well-
100. It's minus 100.
Right. I mean,
Okay,
and again, yes, but what we're
For
following,
for the clinicians, it will be much easier.
and what we're following is the ventricles, right?
Yes.
Like they shunted it, so they want to see how much less the ventricles got, you know. So that's also the part. Like, yes, you can see that there is a difference. In the
Because it
CSF.
also takes into account the separated spaces, right?
Yes.
Okay.
Yes.
So maybe that's also where it comes from.
A little bit, yeah, but like, I mean, essentially, we're seeing that it got shunted, so for the most part, it came off the ventricles. I mean, how much? It would be great. I agree to be able to say what amount of CSF is in the subarachnoid spaces and what amount is in the ventricles. That'd
We
be great.
can't say that yet, huh?
But that we cannot say.
But we could maybe assume that there's quite a lot of CSF that is now not in the subarachnoid spaces anymore, and we actually underestimate the volume that goes in the subarachnoid spaces. We could. I'm just saying.
Yeah.
I don't know either. But
Eventually, but yeah,
maybe that is also something.
physics-wise, it's gonna be hard to say.
Exactly, it's very, very hard to measure, but possibly it's that space is bigger than we think it is.
It could be.
So you're saying it would be helpful to have a ventral segmentation?
Yeah, that would be interesting because I think, like from my visual point of view, from my visual assessment, as a visual neuroradiologist, like what I can see from number 3 to number 4 is that the subarachnoid spaces are decreasing, and the subarachnoid space is quite it's a room, and it's very difficult to measure because it's, you know what it's like.
Now, let me just tell you one thing though.
So I think
You have other volumes too, right?
yes.
So, for example, you know, you also measure like the brain becomes bigger when it starts myelinating more.
Yes.
So when you do follows over time, you don't always follow this over like a day. You follow them over months sometimes. You know, sometimes it's like months after.
Yes.
So if the myelin progress, you can be filling up more extraaxial spaces.
Yes.
You know, so you know this is kind of like where other values also help.
Yes,
You know,
I
so,
agree.
like-
we don't know if it's due to growth or if it's due to
Right.
taking out the fluid, right?
Right, but look, you know, like the myelin the milliliters of myelin, for example, here was 3.3 when this
Yes,
was
I agree.
big, and now it's 47.5.
Oh yes.
Okay, and now
63, yes.
63, and now it's 57. So you say, well, some increment on the CSF spaces next, right? But well, some increment, almost 40 standard deviation of brain parenchyma loss, and depending on 4 standard deviations above normal on CSF volume. So a significant increase in CSF volume for age, because that's the most valuable thing for me. It's all based on age. So this is based on the patient's age, how much CSF volume this patient should have, and there are 4 standard deviations above. So right away, you know, don't really report it as just some benign increment in subarachnoid space, but some significant increase in CSF to explain the macrocephaly. Next. So this is a 2-year-old female with lower holoprosencephaly. Well, the obvious, we are able to follow how much CSF is accumulating, which is great, and assess the progression of the brain volume, which is great. But also, we can see that the myelin correlated volume is 40 standard deviations below. So all these areas that don't look like a big problem in conventional images are significantly decreased in myelin globally. So the brain has a significant decrease of global myelin. And also by doing the conventional images, I don't know if it projects very well, but even on this T1 you can see how this cortex is kind of like featureless and irregular, and it's featureless and irregular and bright here in the midline. So that's the classic brain within the brain of a lower prosencephaly. Something that sticks out very obviously on this, synthetic images. So that was a nice case. Next, this is a patient with seizures, and obviously everybody's going to see that there is some mesial temporal sclerosis on the left. Very obvious. Like that's, anybody can make that diagnosis. However, when I ran the PSIR, the anterior temporal lobe, you compare it to the right. This cortex, it's irregular, it's kind of smooth, it's kind of flat, as opposed to like how the normal cortex looks elsewhere in the brain. And when we do the myelin map, you can see the anterior temporal has some significant decrease in myelin, it's all green. So it's an area of cortical dysplasia that also, it's a feature of cortical dysplasia to have decreased myelination beneath it. So because we had these maps, we were able to detect this occult area of cortical dysplasia that were not very apparent on the flare. And again, you can see that the myelin is decreased in this brain, 2 standard deviation below. Next. So this is a very interesting case. It's a case of Hunter syndrome, it's a lysosomal storage disease, and by pathology, part of the whole pathology finding of Hunter's disease is to have myelination abnormalities. In this case, just based on conventional image, I would say, well, there is some volume loss, prominence of the ventricles, the subarachnoid spaces. But in the myelin map, you can see how this is globally decreased. So this myelin is significantly decreased. 3.3 standard deviation below normal.
And in the graphs, which one?
So in the graph is the third one.
So that's the myelin. And what's the first part?
That's the brain parenchymal fraction, the volume, the brain volume. So yes, of course there is volume loss. There is volume loss, there is increased cerebrospinal fluid, but significant decrease in myelin. So that volume loss is dependent on a significant decrease in myelin.
And also loss in volume. I mean,
oh yeah,
you see this, you think it's an old man.
Yeah.
Old lady. So.
Yeah.
It doesn't look like a child.
Yeah, no, exactly. And that's part of the syndrome, like you have that diffuse volume loss, but we're not stopping at the volume loss.
Yeah.
It's myelin.
So now we can link that the loss in myelin is probably part of the volume loss.
Probably the leading.
Probably.
Because that's how the pathology comes, right? All this caused myelination.
Yeah.
Okay, next. So this is neuromyelitis optica. And again, we don't see much MS on kids, but we have, that's the demyelination that we see. So I'm going to show you in terms of the demyelination, the same thing that I show on the article, on my clinical practice. That we see these areas that, yes, obviously there is a plaque here that is demyelinated, that's not a problem, but we see how there is a decrease in global myelin. You see the myelin correlated volume is almost 40 standard deviation below normal.
Third graph, right?
Yeah, third graph.
Yeah.
Okay, so 40 standard deviation below normal. And you can see like these areas, for example, that on flare you're like, well, I don't know, are those perivascular spaces, are like, but you can see how objectively there is all this decreased myelin in the periventricular white matter. So you can see the areas, and you can see how all the brain has actually decreased myelin in this patient with neuromyelitis optica.
And the subcortical qMRI, is that like pathology or is that normal?
Well,
because it's pretty green, right?
right. So the
Subcortical, so I'm
subcortical,
not at all used to like
Yeah, the subcortical lesions tend to be a little less, but this is
more than they should be.
yeah, which is also, you know, you are 4 standard deviation below, so everything is low. But yes, the subcortical Y-matter can be a little low, but this is too low. But this is not just that, but all the periventricular Y-matter should always be very yellow. And in this case, it's all green. So you can see that very, very easily. Next. So, different case, neurofibromatosis type 1. Again, you have all these foci of myelin vaporization. So you would obviously expect to have less myelin on those foci like this, for example, right? Like right around the posterior limb internal capsule. So, but on the myelin map, you see, yeah, obviously that's a lesion. You can also see another lesion here on the right matter and right cerebellar hemisphere, and you can see like the decrease of myelin there. But you also see a significant decrease in global myelin on this patient with neurofibromatosis, not just on the foci of myelin vaporization, but everywhere else. So next, this is a different case. This is yeah, exactly. So yeah, the kid had an old infarct, you know, but now he's having seizures. And like, oh yeah, he's having seizures because of the infarct. Well, no. No, this is just gliosis for the infarct or whatever. But what is this?
It's a scar.
No, this is cortical dysplasia. This is thickening. The scar is here, but above that, like see the cortex here versus the cortex here, versus how bright it is.
Is it intrauterine infarct or is it?
The patient had some type of vascular, like some type of vasculitis.
So it was postpartum infarct.
Yeah, it was a postpartum. Yeah, now he's 6 years old. It was a postpartum infarct. But aside from the infarct,
it also has something.
it has. So he's not ceasing because of the infarct. He's ceasing because it's got cortical dysplasia. So, and actually we have the FDG PET correlation showing that area.
It's firing.
So, next. So this is 21-month-old female with cerebral palsy, and we obviously see this vascular abnormality. And I read it with the fellow, and the fellow read there are some, you know, right occipital DVA next. Well, how about this cortex here? How about how bright the cortex is here and here, and how much the myelin is decreased in this area compared to this area? So the occipital here versus here, you know, like the myelin volume is significantly low. So there is a significant area of cortical dysplasia here on the right occipital that is associated with a developmental venous anomaly. So what immediately makes it a type 3 focal cortical dysplasia will come in association with other lesions. So the vascular lesion associated with the cortical dysplasia made it a type 3. So we can make immediately a diagnosis of type 3 focal cortical dysplasia. So again, everything matches and it helps. Could we see it without the synthetic images? Maybe, but can you really see it here? I don't know. Can I see it here? Absolutely. So it makes a difference. It makes a difference in your practice.
SWI is not completely out of the sequence.
No, because that's a gradient echo. That's not a spin echo.
True. Yeah.
Not neither is diffusion.
Yeah.
Because,
Okay. Yeah, makes sense.
Yeah, so it's different physics. Anything spin echo.
Okay. Yes.
Anything is spin echo, and at this point only axials, but the 3D is coming.
It's coming. Yeah.
So, next case, 7-year-old female with seizures. It's got a diagnosis of tuberous sclerosis. And again, the same thing. Yes, we have the tumors, which we expect to have less myelin. But look how globally decreased the myelin is on this brain. I mean, in areas that you will see, oh, well, that is like normal, white matter, whatever. Not showing much, but the myelin values are very low. Also in patients with tuberous sclerosis. So we see a common pattern of things that we haven't been describing before in all these patients with debilitating diseases, neurofibromatosis, now tuberous sclerosis, where we can objectively say and follow up in time in these kids saying, yeah, there is a decrease in myelin and now it's progressing, you know. So I think it's a great tool, and I haven't done any research on it, so I don't know how it will progress over time or whatever, but I think it's something that I see in my clinical practice that I can objectively see that it's worth considering and mentioning always that we haven't been talking about before. So, next. So this is a 2-year-old male with epilepsy, obvious case of encephaly, no problem, right? Polymicrogyria, go years without knowing that there is other areas, and this tool allows us to see it much quicker, much faster, you know, like it helps me, it gives me a sense of security to have all these additional sequences and all these maps to be able to say, yeah, there is cortical dysplasia, there is not. So, and you can also see how, you know, like there is all this green here around this area, this cortical area, that is not actually on the other side. And so you can actually see. Next. Almost there. Don't lose me. So, another case of seizures, like we see a lot of seizures, it helps me a lot. You know, so we see this case, obviously same thing, you know, mesial temporal sclerosis, you know, like the temporal looks a little, you know, there is something going on here, right, like low on T1, high on T2, on the medial temporal lobe. You know, that's the obvious, everybody saw that. But nobody saw is this. Look at the cortex here. That cortex is abnormal. Compared to the cortex on the other side, it's significantly abnormal. And it's significantly abnormal and bright in the double IR. So these PSIR and double IR sequences are super important in the diagnosis of cortical dysplasia. And they don't come standard in our regular protocols that we scan in our daily practice, but it comes easy and standard on the synthetic images. So help me find right away this additional area, because in seizures it's not what you see. It's a lot of times, like I'm showing, you see something and you stop there, and then there is something more, and that's what these patients don't respond to treatment, because you know they do epilepsy surgery, they take the temporal lobe, well, there is more, and the patient is still seizing. You know? So that happens all the time. And I think it's my last case. Next. Yes, so this is a 10-year-old female with cerebral palsy, obvious findings of periventricular leukomalacia, but we can now objectively say how much decreased the myelin volume is. You see how the periventricular white matter is all green and even like not registering in some parts, depending on the significant loss of periventricular white matter on DBL, 3.4 standard deviations. Below normal for a 6.2 standard deviation, below normal in the volumes and the myelin. And you know, that's all I have.